The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code PhysioCoach2MO, that's PhysioCoach2MO, to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's better physio. The eyes can only see what they know. And this was a phrase that has stuck in my head ever since you said this the other day, Benoy. So I've got Benoy Mathew here, advanced practice physiotherapist. Very, very grateful to have you here in the studio today, talking all about hips. It's been a bit of a season of hips for us as a podcast, actually. With a colleague of yours, Yasmin's episode was released a few weeks back, and we've got our live episode, which at this point we're recording it next week, but would have been released as well by now. So a real season of hips. Yes. So I'm very grateful to have you here, Benoy. And I'm going to come back to that phrase, the eyes can only see what they know. And the thing that really stuck to me there is it drew me back to my early days as a physio, thinking that I knew everything, that old classic Dunning-Kruger effect, where you're on the top of that Mount Stupid in the Dunning-Kruger effect, and then suddenly this moment of realization that you actually know nothing. Yeah. And you spend the rest of your career building up knowledge and expertise and patterns in your mind, learning about this thing that we do, this thing called physio, this clinical reasoning that we have to develop. And what this learning process is all about is giving the eyes more information so that they know more and they pick things up. And your specialism in particular obviously is hips, but also it's second opinions and probably third and fourth opinions, is picking things up that other people's eyes haven't been able to realize. So we're going to launch into the episode with not quite quick fire, but a few quick fire differential diagnosis options for people to consider around the cases that you see, which often are things that the obvious isn't the thing, it's something else. So welcome to the podcast, Benoy, and over to you. Tell us a bit about the differentials.
Yeah, so thanks, Charlie. So great to be here. I've been listening to a few of your podcasts and great to have that setting. And also it's good to have the chat before. And I think, one of the things I would say is everything depends on the setting. So one thing I want to make it very clear is common things happen more commonly. So if you're going to see a hip in a normal MSK setting, your bread and butter will be your hip osteoarthritis, your GTPS, your hip impingement, occasional adductor related groin pain. That's possibly going to be 80% of your caseload. And that's where, it's always good to keep that in mind, because sometimes we could get carried away with all the fancy diagnosis, which you might see once in 3 years. So you always start with that basic 3 or 4 conditions, which I think most physios are aware of. And I rarely see them because, we are quite good with all the, awareness of the hips. So most people are having picked it up. So when people see me, most of the time, the symptoms are anywhere from 6 months to 3 years. That's they've been around for a while, So the context is really important because these people, the duration is for a while. So if you see somebody with hip pain, maybe 4 weeks or 2 months, this might not apply, So this is chronic cases. Maybe they've done generic rehab or it's not responding. So we're looking at patients. There are 2-3 reasons people come in. One is they don't have clarity. They've been told different things. The second is it's not getting the result they want. And a big group who come in also, which I'm surprised, is they really want me to tell them that you need surgery or you need injection. They already decided, but they want somebody to just confirm what they already know. So it's a bit of a relief for them, But again, it's good to have a structure. So you've done your obvious one. And I can only tell from my experience in the last 15 years from the hips thing. So I have a checklist, which I use is, okay, you've tried the normal thing. What are the most common? So I'm going to say in the order of what I see the most common. So the first one, which is unfortunately most commonly missed or misdiagnosed, has to be hip dysplasia in young active women. So it could be anywhere from as young as 15 to usually 32, something like that. So they're quite young. And usually there are many reasons for that. It might be always useful to know why it's missed. It's not like, so that physios can pick that up and help, rather than just, we're not trying to blame anyone. It's just knowing why are they missed, I think the first reason is most of the symptoms in hip dysplasia in the early stages is very non-specific. They behave like GTPS. They behave like a little bit like impingement, and they behave like a bit of overload, vague activities related pain. It's not nothing dramatic, but then the decline is quite rapid. Then they start really limping. They stop all activities. So that's one reason. The second reason is, unfortunately, especially in the private side, people rush into MRI very quickly. So you got to run a bit of pain, go to a consultant or anyone, get an MRI. And there are two things. So if I get a bit of a joke when I say on my courses is, if somebody comes to with me in a MRI of the hip, there are two things I can close my eyes and say they'll be there on the report. One is a labral tear, and the second is gluteal medius tendinopathy. It's a very common incidental finding, So the question is, it's sometimes, most of the time, it's not relevant, So it doesn't really help you.
It's the classic disc bulge of the hip. Right?
Yeah, it's a disc bulge, or a rotatory cuff, supraspinal tendinopathy or something like that. So those two things are standard MRI report, A bit of labral tear, a bit of gluteal tendinopathy has no relevance to the symptoms at all, But then people get onto that role, have an injection, do a bit of rehab, so they go around. So I think the MRI generally is a problem because normally you need specific views of an X-ray, which we can, if we have time, we can go through. So the MRI is not really useful. And I work as advanced practice in the NHS as well as in private. I don't think it's any better in both the sides, It's always, even if I ask for it, it's missed, So your chances are less than 50%. So one of the key messages I want to say is, don't bother about the report. If you think there's something intra-articular, do your bit and refer on to a specialist, Don't hold on to a patient just because it's come back as normal or a bit of labral tear, Sometimes when the early part of a career, when I didn't really know what was happening, I would say, chronic intra-articular hip pain for further review. That's it. I don't need to know what exactly. I've done my bit. So that's the second bit where it happens. And there's sort of misconception where a lot of therapists know that dysplasia doesn't happen like outside childhood. You don't need to have childhood hip dysplasia to develop adult dysplasia. 90% of hip dysplasia happens during teenage and when you are a young adult. You can have a perfectly normal childhood where you can do that. So those are potential some of the reasons I feel dysplasia is delayed. And you look at the stats, it's something like 5 years before people get diagnosed. So I think that's definitely number one. And then moving on to number two, which I think more common, which is getting better now, is early stage femoral neck bone stress, grade 1, grade 2. So you got a typical runner, again a female, bit of a niggling groin pain, treated as tightness or a hip impingement, but it's not. It's just your grade 2, and you can still run with a grade 2, grade 3. And those are very tricky because if you look at the hop test, it's very good for picking up for bone stress, but it's positive for everything for the hip. If you've got FA flare up, it's positive. So it doesn't really differentiate.
The thing that I often look for in those situations is that, like, what is the face actually telling you here?
Yeah.
Like there's sometimes something different about it. Certainly, I mean, you've clearly seen a lot more of them than me, but the ones that I pick up in those bone stress injuries, there's something different about the quality and their body language.
Bones,
Yeah. They're really not comfortable at all. Whereas when they're in pain, they say, yeah, that hurts.
Yeah.
But they don't look like they're like, oh, wow, there's just something
the lack
different.
of spontaneity is there, when you assess them.
Yeah.
So again, that's where I think some of the risk factors. So I think when I get a female runner, I would say my 90% of my judgment of high-risk bone stress is based on 3-4 questions. So the first question I'll ask them is, did you play a lot of rotational sports when you're young? We know 90% of your peak bone mass is achieved before the age of 20. So if you are a female or a male, have not done a lot of sports before the age of 20 and you start running at 28, you are in a lot of risk on that. Yeah. And the second is obviously the age of your periods. We call them, the first menarche, where if you have 2 female runners, one female runner, her first period was 15, whereas the other one was 12. The one who had at the first period 15, she is high risk for the rest of her life. So that is an important fact, So I always ask them when the first period is. Most people will know that, So that puts them at a high risk as well. And
why does it put them at high risk?
Because I think you don't get that enough ovulation and the estrogen, all that, which really sets the bone. So they missed out on the 3-4 years of bone building. And unfortunately, that can be, I'm not saying it's a non-modifiable factor, but those are, so give you an example, like I had this patient who was a bit frustrated because her colleague, she and a friend started running at the same time in the late 20s. She was getting injured all the time, whereas her friend was easily going to marathon. I said, your friend was training a lot before the age of 20. She had a lot of reserve, She was playing netball. She had the bone health. So sometimes people compare same age, but your sporting history is different, isn't it?
Yeah.
So you need to always keep that in mind, So,
yeah, my wife, she gets an occasional mention on the show, and she's a recent runner. She started running in the last 3 years, and prior to that, she wasn't particularly sporty. She did some weightlifting in her 20s, but she wasn't sporty as a kid, and she has to be very careful. Because I occasionally physio for her on the kind of niggles and the early onset stuff. And often it is about load management for her and being aware and dietary stuff and making sure that she's careful there, because I've explained the same thing. She wasn't sporty. She didn't lay down all that bone mass. She didn't have all of that resilience in reserve.
And the change of direction, the agility and all that stuff.
Yeah, so she's very sensitive to a spike in loading. Whereas I played loads of sports as a kid. Look, I get injured as well, but I've got a bit more reserve. I can push harder for a few weeks, and I seem to get away with it more than. And she looks at me. She's like, how can you do that? And yet you keep telling me to do it this way. And it's like, well, we had very different developmental years. And
that sort of that advantage, unfortunately, is for. And there's one study which showed if you do a lot of rotational sports before the age of 18, 20, it protects you up to another 30 years. It's a bit unfair. It's like investing in Apple 20 years ago. You're going to reap the rewards for it.
But as a parent, actually, and there'll be a lot of parents listening to this, as a parent, it makes it even more important that we keep our kids active as long as possible, right?
Definitely. Especially, if you've got girls, because we know the bone health much more important because of the changes we have. So the first 16 to 18 years really sets the scene. And also, another thing is also, we know that the carb side of things, this can be a bit of a problem. We know sometimes people say that enough calories, but sometimes it's the timing, so they're overall eating 2,000 or 3,000 calories, but not enough carbs or not timing before the. So I really ask them, do you eat anything before the run or after the run? Things like that. I'm not a nutritionist, but as a therapist, I need to really know.
Same. I'm not a nutritionist either, but I ask these questions because I know that it's within my scope to at least signpost someone towards good information.
Yeah.
And I know that same information as well. And if someone is running fasted, there is definitely a difference there. That seems to make a difference. And I guide that as well.
Yeah. So that's the second one and hopefully, I've seen your podcast, you try to raise awareness on bone stress, and that's everywhere on social media, isn't it? So many on that. So that's the second one. And the third one, obviously, is one of my favorite topics. It's quite a pesky, it's quite an annoying condition because it can mask quite well, is Proximal ITB Syndrome. So for something so superficial, it comes like a deep ache. So many patients will say, I feel like a deep ache in my bones. Obviously, they'll come with tenderness around the proximal ITB. I saw a patient last week where a pain was even referred to her big toe. So it causes like a pseudoradicular pain.
Yeah.
But the main thing is it's like a tightness and a grabbing feeling around and for something so tiny, because I do a lot of ultrasound, it's a little bit of thickening. You think this can't cause such pain, but it's quite debilitating. So you get thickening of the ITB at the origin, around the iliac crest, and it's nearly always females, and it creates that sort of whole area gets shut down. And unfortunately, most MRIs don't include that view. So you get missed. So X-rays will not pick up, obviously. And the only option is picked up on a simple, diagnostic ultrasound. So, and again, the rehab is very similar to GTPS, but again, it's one of those conditions where it's disproportionate to the pathology, For something so tiny, you'd think it's not a big deal. But I see people debilitated. I had one patient in the NHS. She was in her 60s with the condition, and she was taking Oromorph. And the first time I was seeing somebody on Oromorph for proximal ITB syndrome. So I'm still learning a lot about this condition, but I see at least 4 or 5 a month, possibly more than most people. And obviously this always been there, but now we have given a name to it,
Yeah.
So it's again, so if you have a active or inactive female, pain more towards the proximal iliac crest region, and the MRI is normal, then possibly find somebody who can do a simple point of care ultrasound to confirm it. And it's one of those simplest things to treat, once you know what you're dealing with.
And do you think that people accidentally treat this when they're treating? They think they might be treating something else, and they don't have the diagnosis, but they get away with it. It's like it's
like myofascial TFL pain, or something like that, So you call it that. But again, it's quite a stubborn condition. It's quite nagging. It stays on for a while. And what I find anecdotally is there's no publication. It's usually linked with crossover gait. So people have the crossover gait, tend to have this issue. So you have to look at the gait mechanics, look at the hip abductor strength, or like I'm sure you also check, like you guys have Val here. I also check hip abductor strength, So getting those data is real. But I think a big relief for the patient is when they know that there's something wrong. So I tell them, this is a condition, we can help you on that. But before that, they have this vague labels, bit of tightness, bit of hip impingement, bit of dysplasia, but it's not. So for something so tiny, an extra-articular condition, the proximal ITB it punches above its ground for the symptoms, So you think, I used to dismiss it. I think, what's a big deal, But the symptoms are quite devastating for the patient. So that's something to keep in mind.
Do you think someone needs to get, if they're suspecting that diagnostically, do you think someone needs to get the scan in order to rehab it? Or do you think they can just crack on and rehab it?
Yeah, but I think the patient sometimes don't engage because they don't believe it.
Yeah.
Because they feel like it can't be that. It's something bigger. Many patients think, no, it is not that, And then I show them. It's more like confirmation. Because it's so vague and diffuse, they can't believe that. They think it's something from the back, So sometimes it's more the buy-in rather than, I don't think it's necessary, but depends on the setting.
Yeah.
And if they had it for a long term, then they are more likely to not buy in.
Yeah.
Your argument as well. So that's the third one to look into. And then the fourth one, which is one of the things where, just to be honest here, I still feel I'm not very confident with the imaging, is a condition called Ischiofemoral Impingement. So give you a profile. So somebody usually like early female, active female in the 40s, being sent to me as non-responding proximal hamstring tendinopathy. So typical middle-aged runner, not improving with proximal hamstring tendinopathy, and they book with me. And every exercise you're doing for proximal hamstring is making them worse, especially end range extension, your bridging, your deep lunge, your high step ups. That is a suspicion of ischiofemoral impingement. So end range extension is a problem because the muscle, which is the quadratus femoris, gets really irritated and inflamed. So these people, mostly women tend to have a genetic variation called anteversion. So they generally have a lot of rotation in the front and they really overstretch and irritate. So they are predisposed, but then as they get older, the muscle tone reduces. And when you MRI them, you see there's a lot of edema of the quadratus femoris. And so if you have a patient with proximal hamstring not improving, that's the first thing you should be thinking. Is it ischiofemoral impingement? And there's a simple test, something called the long stride test, make them to a long stride. And a key question, so you got a runner and saying, when you run, what stage you get the pain? So somebody with a proximal hamstring, it's on the heel strike, because that's when you're stretching it. But somebody with ischiofemoral impingement, it's on end range, it's on the toe off. It's when they go on that. That simple question is all you need, Yeah. When does it happen? Is it when you stretch it or when you go into end range extension, So that will help you. And that's, again, a beautiful condition where you can pick it up on an MRI. So you don't need anything. You can confirm it on MRI. If it's very irritable, I have 2-3 sports doc. I work with a simple guided injection, just like anything, calm it down.
Yeah.
I've never sent anyone for surgery, calm it down, work on the abductors, external rotators, look at reducing overstride. I find a lot of these people overstride. So most of the cadence is less, correct the mechanics. Bit of a slow condition, 3 to 6 months, you can really get them back to full level as well. So a failed proximal hamstring, that's the first thing I'm thinking, especially if it's female. The last condition, which is quite unique, is not well known, is osteitis pubis, where it's basically you get bone marrow edema around the pubic region. There are 2 types of people I see, 2 or 3 types. One is, a female who just had a baby and started running recently. They rushed maybe too early, or maybe they're not ready, and they start getting a bit of a lower abdominal pain and a bit of medial thigh pain. So they end up having extensive tests for gynecology and everything is normal. And finally, somebody does an MRI of the hip, and then it shows a lot of bruising on that. So that's basically, it's like a stress reaction of the pubic bone. But the weird thing about this condition is it can refer everywhere. So they'll come with medial thigh pain here, and they'll come with like something was wrong with your stomach, like indigestion. So a lot of people waste a lot of appointment going with abdominal surgeons. They'll do scopes, they'll do all this stuff, nothing wrong with the tummy, Or they go into urology, see the urologist, check the bladder, everything's normal. The people who refer me these patients are generally women's health physio. So they've done the pelvic floor side of things, So they pick up. The second group who get this is generally middle-aged men, usually 50 plus, who are doing ultramarathons. So as we get older, one of the things as we get older is men tend to lose hip extension and hip mobility much more than women. And that lack of mobility overstrains that region. And it's just an overload, just like shin's pain really gets inflamed. And it's a bit of scary condition in men because nearly every patient I've seen with men with this, they will come with severe testicular pain. They get pain in the balls and they get pain after ejaculation during sex. Really freaks out the men, because they think, what the hell is happening? Do I have got testicular cancer? And they end up going around the blocks with urologists, which is the right thing to make sure they don't have cancer. So I don't really understand why that does it, but a lot of men with the osteitis pubis get like a genital pain, like heaviness there. And it's very distressing for that. Once you rehab them, once they're better, that goes away. So the first thing, my main job on day one is to say that the testicular pain is the referred pain. There's nothing wrong there. Once the rehab gets better, then because men really shut down when they get, like it's a normal thing, isn't it? If you get pain in your balls all the time.
Well, even us at MSK first line practitioners, we're going to ask them that question, and they say, "Oh, I've got pain in my testicles," and we'll think, red flag, we need to send them away, right? But as much as that might still be the right thing to do on one hand, we can still do our due diligence and think more broadly about the osteitis pubis here, right? And that's what you're getting at.
Yeah. Now, hopefully, these are people who are active. They've done sporting here. So usually a lot of long distance running, or although they come in from, they might also have adductor related groin pain coexisting, So another combination is a young male who has chronic adductor related groin pain plus osteitis pubis. They have both. So a typical footballer, I think there have been few famous footballers in the media who have been long. I think, I don't know whether it's Yamal or somebody, a long time ago, like he was away for a period, so very common in professional football as well. I don't treat professional football, but the only people I see is that postpartum female runners or middle-aged runners who really ramp up the volume and who don't have good hip mobility. Because my guess is when you don't have hip mobility, there's not enough range to dissipate the forces, and it just shuts down the whole region, and the body reacts by bone marrow edema, and the whole muscles becomes like inhibited, and then maybe starts irritating the nerves around that region, and you get all this weird referral pain.
I say this all the time in my sessions. It's like we don't really understand pain. So all the time, it's like it moves around in weird and wonderful ways, and every day I'm surprised at where people feel pain based on the injury they have.
Yeah,
it's just one of those things, and there's certain patterns to things, but even then, sometimes it gets a bit weird. And
I want to put a bonus there because I've just seen two patients today. Fortunately, it's not a very common condition, but it's one of those debilitating condition ever. It's a condition called Pudendal Neuralgia. So you got the pudendal nerve, which supplies the medial, side of the groin, plus also to the genitals. So there are 2-3 types of people I see. The most common is male cyclist. So they're sitting on long periods and they feel the. So first thing they'll notice is the numbness. They laugh it off. Like typical men, they don't think it's a big deal. They feel numb. They can't feel the penis at all. They think it's not a big deal. And then after 6 months, it starts burning. They get like the shooting pain. And then you go to GP or a FCP or some people think you got cauda equina. You get an MRI of the lumbar spine, it's totally fine. And then you get also in women after they're given childbirth or they had some gynecologic surgery, they'll have the sitting pain. The problem with this condition is every investigation under the sun will come back as normal. MRI is normal, no conduction is normal. And the people start losing their head because something is wrong, but nobody is able to pinpoint it. So it's one of those specialist knowledge diagnosis, It's unless you're in that field, you won't really know. Only few physios, unless you're like a women's health physio or pain clinic guy or a hip guy, it's not something most MSK physios know that. I think one of the thing I want to raise from the podcast today is just put out there is there's a condition which you might see possibly 1 in 2 years. So if you have somebody who has the same symptoms as cauda equina, but on one side and the MRI is normal, then more likely it's pudendal neuralgia. Please refer to a pelvic health specialist who can get that checked in. Don't bother, of course do an MRI, but a normal MRI is more like ruling out any red flags like pelvic tumors and things like that. It's not picked up on MRIs. It's not picked up on nerve conduction studies, So it's a diagnosis of exclusion,
And how do you treat it?
Yeah, so the 2-3 things here is 2-3 involvement. So one is I work very closely, nearly all of them will have involvement of the pelvic floor. So as a hip physio, for me, one of my game changers is working very closely with pelvic floor physios. So I got a male pelvic health physio, I got a women's health pelvic health physio. So first thing is to calm down that internal side to really work on that. And I find there's a lot of weakness around the hip external rotators. So I really work on the hip external rotator strengthening side of things, give advice on reducing too much of sitting, stuff like that. And they tend to give advice on the bladder. So things like not reducing the coffee, drinking lots of water, things like that. And this is a funny story, really, because this shows you sometimes how you have to push the boundaries. So I was teaching a Shockwave course around 6 years ago, and I was showing them like Shockwave for proximal hamstring in the course. This was like 6 years ago. During my lunch break, one of the women's health physio who was attending the course came and said, I'm having this condition. It's really debilitating. Do you want to try it on my pudendal nerve? I said, I don't think it's a good idea. I don't think nobody has done it. I looked up on the literature. I don't think I want to do that. She persisted. I said, okay, I'll do it on 2 conditions. I'm going to make a clean, big consent form, and I'm going to have two colleagues in my room with me, purely make sure to cover myself. I don't want to be in trouble there. I said, okay, I'll do it because I know the location. I gave a very low dose. It's focus shockwave. So I gave a very low dosage of focus shockwave and said to her, you could make it worse, but you take the risks, And she was happy with that. And she called me like 2 weeks ago and said, I'm 60% better. And I said, oh, okay. Do you want to come back? Let's do 2 more, 1 more. Normally I do a course of 3. And she was like 80 to 90% better. And I thought, okay, maybe it's beginner's luck. So I thought I need to share this to other pelvic health physios. So I contacted Simon Good, link with an expert called Bill Taylor. So he's like a pelvic health, guru there. I called him up, shared the protocol. I've taught this with many people, and they had similar success. So this is unpublished, pure accidental protocol. But I've been using it for I've done at least 50, 60 patients now. And it's pretty good. It works on that. But again, I would want somebody to publish on that. So if you guys, anyone in the audience, if you're interested in publishing and want to know that, please contact me, I'll be happy to share that, But again, it's one of those things, isn't it?
Yeah. I think that's so. I hadn't heard that before. I didn't know of that. And as you say, it's not published. So
yeah. And I don't want to be saying like this. I don't want to come up like this is Benoy's product. This is just an accident. Somebody told me try it.
It's okay. We can call it Benoy's protocol because you started it. I think it's only fair.
Yeah. So again, the key thing is don't miss pudendal neuralgia on that. So again, you got this 5-6 condition, but let's not forget the most important will be that your dysplasia, your femoral neck bone stress, your proximal ITB, and also looking at osteitis, pubis, things like that. So I've given you a bit of a checklist here, and hopefully that can raise awareness. That's the whole point of.
You clearly love solving problems, Benoy. It came across very, very obviously to me when we had our chat. You're a problem solver by nature.
Yeah.
How did you? Physio is a problem-solving profession, and I imagine it was a good match from there. But tell the audience a bit about your early days as a physio, getting into physio, and then the career change you made 15 years or so ago.
Yeah. So I think for me, the problem-solving came around 15 years, which is same time where I come in. So I was sort of early part of my physio career, I was going around. I didn't have like it might be useful here. So I started in MSK, and even before Saudi was famous, I was working in Saudi around in the early 2000. And the mistake I did was I went to a center where I didn't really have much of support and mentorship. So I was working in a center, lots of ACL, no support, basically burned out, because I felt I couldn't handle that. So I left it. Then I come and started with inpatient. So I did that for about 6-7 years, went to respiratory. So everything was fine. So I was not like, career was not a big thing, I was just doing work, I was happy with that. But then I had this sort of niggling knee injury. I didn't really have any specific injury. Looking back, maybe I went for skiing 6 months ago. Maybe I did injure it, but there was nothing really I could pinpoint. So I had this vague medial knee pain, very pinpoint, very mechanical. I was a respiratory physio, so obviously I didn't know. I thought it was meniscus. So I went and seen few my colleagues. They said it's meniscus. Did rehab, no change. So long story. So basically, I spent nearly 3 years with about 4 MRIs done. Nobody could pinpoint what was wrong, and that really was one of my frustrating years of my life. Is that uncertainty? Is something is terrible. It was quite debilitating pain, and that made me really anxious because nobody was believing me. And people said, "Oh, you're stressing out. You need to chill. Have some chronic pain classes. Take some amitriptyline, all that stuff. And then finally, I got my GP to refer me to Stanmore. So I went to Professor Briggs, so one of the leading guys, and then, and then finally, they found like I had quite a significant chondral defect, and then they did like a first day, which was microfracture, didn't work, and then I had to go for an implant. So basically, I ended up with 4 major surgeries. So that really made me think a lot of people must be going through what I'm going through. That frustration of really not having a label and not really knowing the option. So that's what really made me passionate about complex cases, because I think I'm not saying I got all the answers, but those patients need to be heard well and given a new outlook there. So that's really got me triggered. And then what made me into MSK was I was rehabbing it, but I felt like the rehab was not optimal. So I was put in a group generic NHS class, but I was just doing some circuit training. I was not happy with that. I thought like I need to learn more about MSK. So I read up myself, looked into SNC. Obviously, I was still working as a respiratory. So reading up on my own time, looking up online. Obviously, at the time, we didn't have world-class podcasts and all the stuff. I'm talking quite, 2009, 10 sort of time. So it was pretty much going journals, looking at the library. And I thought, okay, I like that. So let me make the move. So, and I decided to make the move. I thought I want to be an MSK physio. And just for an audience, I got my job in my MSK physio on my 14th interview. So people thought I was crazy because I was a team lead of respiratory. I was leading teams. I was like a high 8A.
So you were getting pushed away because you were overqualified.
They said, we can't. I don't understand why a clinical lead, he wants to do a band 6, because I know they won't employ me as a band 7. So I thought, you're crazy. We're not. This is long back, because at the time, so they said we're not giving. So on the 14th interview, I was nearly so close to giving up. So I thought. So I started as a 6 again, and it was a big risk for me financially as well. I just had a new baby. We had a new baby as well. So I thought my partner was saying, "What are you doing here? You got a good job. It's not what you want." But I was so frustrated with my and just people talk about burnout. I was only working 37.5, but I was so tired because I felt I was not going anywhere. I wanted to leave. And I was in my 30s as well. And people are saying, "Why do you want to change now? Everything's good. I've already done an MSc in respiratory. I will spend a lot of work on that." And to start all over again in my 30s in a new career, I was the only person I knew of at that time. Obviously, I've seen many colleagues do it after, and that was quite daunting to make that change, start from zero again.
Is it possible that change, though, has prevented a midlife crisis type situation, right? Because you're in your 30s feeling the symptoms of burnout, not, as you quite rightly say, not because you were doing too many hours, but because you were doing a job you didn't really care for.
Yeah.
It wasn't for you.
And I thought I'd done enough,
Yeah.
Maybe sometimes everything has an expiry date, Maybe you love sometimes everything, like maybe even MSK, there might be a date where you feel I need to do something different, And there's nothing wrong with that. Yeah. And what you love now, maybe in 8 years, it's no more relevant, Maybe you've grown out of it. And I loved respiratory. That's why I did it for so long. But the time has come. I felt I couldn't grow more, and I felt I could do more with MSK. So I started back with the MSK side, and again from that. So when people say, I laugh when I get junior staff and say I'm too old to make a change, and they're like 28, and I think, oh God, you come on, sort of people. Sometimes we put all the barriers there, when they say like you could start anytime. But obviously, older you are, and you got kids, and I think it's much harder, I would say, So, but if you feel like you need to reinvent yourself, you can do that.
Something our customers keep telling us about Jane App is that she is really good at reminding them about their appointments. Quite persistent at times, but as a result, people do keep turning up to their appointments on time, on the right day. You can set how many times the reminders come out. You can set the wording in the reminders. And as a result, we have seen a significant reduction in the amount of late cancellations and non-arrivals. So if people can't make it, they let us know with plenty of time. And people get reminded on the day, so they often do turn up. They don't let work get in the way. We're really pleased with it. Works really well. One of my customers has even started to refer to Jane as his PA because she's so good at keeping him organised. So yeah, it really does seem to work well for that. And now back to the episode. So your knee injury, the complicated 4 surgery, no one believed you, chronic pain, that got you into MSK.
Yeah.
How on earth did you end up at the hip?
Yeah, so hip again, like it's all healthy accident. So I always wanted to do good. So because of my knee rehab, I got a good basis of lower limb rehab. So I built up. So every job I was going, people had this reputation that you're good in your lower limb rehab. So I was sort of more the knee, foot and ankle, hip guy. So when I was working in Hammersmith, we used to get a lot of hips, and for some reason, people used to just lump me those patients and said, we don't want this groin pain. You're good in lower limb, just see those hips. It's same like the knee. So I used to treat hips very much like the knee, because my knowledge was only knee, by myself. I've seen ACLs, I've seen my knee. So I treated a lot of the hips purely because of the referral from my colleagues. And they thought this is quite interesting. So I was very curious. I was not interested at all in hips. It was curious. And I looked up, one of my colleagues had a hip arthroscopy surgery, and she came with the report, and she came with post-op. This is like 2011, I think. And there was no good rehab. So I thought there's a problem here. There's a lot more surgeries happening, but it's not good rehab, not good protocol here. I thought maybe I can get into it, So then what I decided was to shadow it. So it's only after the second or third year where I start really enjoying that, because I felt, so for me, it was more like a problem was there. And that's something I can do something about it. That's my outlook. Where it's not like I won't be like the hip guru or like teach course or anything like that. I felt there's a niche, there's a problem. So it's more like something already exists there, which I don't have to create, And that's how it led me into that path of going into the hip side. And of course, I love it now. But for me, it's more driven by curiosity and a need. And so sometimes people ask me like, what's your passion sort of thing. Sometimes the passion comes in once you get competent. So competence sometimes leads to passion, So that skill level will naturally lead to that sort of passion, because very few people will suddenly wake up and say, I want to treat ankles, or I want to treat shoulders, or I feel like you will have an inkling, but I think you have to go with the experience and your competence, isn't it? The skills.
Yeah. So sometimes it works the other way around.
Yes.
Some people could easily have ended up a knee specialist given your story,
I could have been a knee on
Yeah.
that, and that would totally fine, because if I got on that, but I think the timing, and a lot of times is the timings and the experience, and you do the best with what you have and what you get, So I was exposed that time, and I took the opportunity there, So if I didn't have the exposure, I wouldn't be in the hip at all, All we can do is make the best of the opportunities we get, isn't it? And put yourself in the best opportunities possible, So what I did was, I said to my colleagues, I love lower limb rehab. Send me your complex lower limb. That's what I wanted, I took complex hips, complex knees, and foot and ankle. And then naturally but you have to put yourself out there though, to say that I want those cases, isn't it?
At my last job, I was asked, what's your specialism?
Yeah.
And I had to scratch my head a bit, and the regular listeners will know that I'm a generalist physio by trade. I don't mind seeing a bit of everything, but I also, like you, like solving complex problems. So that was what I came up with. I'm a specialist at solving complex problems.
Yeah.
So I then started to get a lot of chronic pain come my way, a lot of second, third opinions come my way, and there's a good chunk of those that I wasn't entirely sure what to do with, but I was very curious and I was really determined, and I had good communication skills. So I learned through a lot of error, I would say, in that. And people that have had pain for 2 or 3 years, they're often a bit more patient, actually.
Yeah.
They don't expect to be better next week.
Yeah.
So they'll give you some time. They'll give you some energy, and you could work with them if you're willing to think outside the box.
And the thing was, I realized is the only way you can get better, this is something, and numbers don't lie. One of the only ways you can get better is by seeing more. Yeah. So what I did for the first 5 years, long before I was teaching courses or anything, was every place I went, I say, please send me the hips. I just want to get better at it. I was not good at it. Nobody's good at it initially. Yeah. But once you're starting seeing more and more, but you tell people, and they were more than happy to do that because they didn't want it.
They didn't want the hips.
They said, send me your hips there. Let me see it. And once you've done 200, 300, 500, 600, it becomes second nature, isn't it? So once you know that, I would say is get the volume in. There's no substitute to volume. You have to see all variety. And another one is also, which I massively helped, was I was I was struggling with understanding hip dysplasia for a while. So I was reading up, I was doing my own research, and I thought like, I was early, maybe 2012 or 13. So I decided I can't, I contacted UCL, and I think Johan Witt, fortunately at the time, he gave me a chance to sit few clinics with him at UCL. And that really opened my mind on the whole path, because you have this idea of an adult hip, but when you sit with an expert, see his thinking, see how he sees the X-ray, what I learned in that 2 days really was 10 times more what I've learned myself the last 3-4 years. So sometimes spending a time with an expert fast tracks your career massively. And that's something I do even now. At least 2 or 3 times a year, I'll sit with consultants or other physios there. That's one of the best things you can do, in my opinion.
We had this conversation the other night, how surprised we both were that we don't get more requests for people to come and spend time with us. Yeah. And whenever someone asks me, I do my best to accommodate. And, but I am quite surprised how few people do reach out and say, hey, I'd love to spend some time with you. I'd love to learn a bit from you. Yeah. And I think there's a caveat to this. You know, you quite rightly raised that you could get inundated with people just saying, hey, what's my diagnosis for such, but this, and this. It's like, actually, you want someone who's genuinely interested in learning and has got something to say about themselves. But I reflected on it and thought, yeah, I'm quite surprised, given that I've put myself out there and on a podcast and social media, and
you're accessible. You know,
I'm in London, central London. Yeah. So quite surprised that that not as many people come out, reach out, and want to spend time just chatting sometimes. But perhaps this is the floodgates that are opening here.
But again, like I told you the story, which I still laugh at it. Like I was teaching in Norway, and I got an email like 3-4 weeks ago. It said like, you're coming on Norway. I know you're teaching there. I can't attend the course because I'm a student, or something he couldn't afford, or something. He said, can I take you out for dinner while you're in that staying? I said, okay, I'm not doing nothing. I'm just staying in the hotel. So we met up, had a drink. I paid for he said I didn't feel good on that. We shared that. But, that 3 hours, he said to me that he found it was really useful. And so again, when you're seeing someone, you just see, if you're seeing somebody in a conference or in a public forum, just approach them and say, can I pick your brain, on that? So again, like, just give an example, like, I work in a very busy secondary care hospital or other places. When I walk in, I would say maybe in the last 6 months, or maybe only 2 people have stopped me and asked me some questions. I'm not going to say, obviously I'm in a very busy. So again, people sometimes feel like, oh, he's so busy. If you're there, you can always ask them, isn't it? And say, can you give some tips? So I find really surprising that when I was a band 6, I used to bombard my APPs, lunchtime, and I'd say, what should I read? What should I do? So maybe they found me annoying, but for me, that was the best thing, really. For me, when you got somebody with expertise here, why should I let it waste away, If you have an opportunity, because I'm not saying you have to travel all the way here. If you see somebody, you met them on a conference, you met them coffee, stop on the way and say, Charlie, can I just pick a few minutes here, I'm sure you will give that, isn't it?
Absolutely. I mean, I love helping the next generation, right? So or this generation, just chatting to someone who's the same experience or whatever. It's like open forum, let's chat about it. The whole podcast is built on that very premise, trying to have these conversations in a more public space.
Yeah, but one thing we have to thing is, you must get this, where I get a random, like quite a few emails on the DM and say, oh, I've got this 28-year-old female with hip pain, groin, blah, blah, a long list. This is the MRI. Can you tell me what to do? And that becomes more like a clinical query, isn't it? It's like me calling up a lawyer and saying, I've got these things, I've got this letter, I've got this mortgage. Can you give me advice? Would you get that?
I think there's a clear difference here. One of them is asking for support on their learning, and one of them's asking for an answer. And that's like, if they're looking for a service, then they have to go via the normal channels, right? Booking for a session, online, whatever, physical, in person. Yeah. But if someone's looking to genuinely learn, and great, let's have a conversation.
That, because the thing is, and again, like being honest with them, and I'm sure I love seeing people have the curiosity and the drive, which in fact it's a bit of maybe showing my age. It sort of reminds me of what I was. It's like that sort of passion there, and you drive and you're going the go-getter there, because it's a good thing, and we need more physios to really push that. The way. Each one of us, we try to push it. The next generation makes it much easier, like the way I try to push. Just one example with the Pudendal Neuralgia. Hopefully somebody will pick that up and they'll do more research. It has to start somewhere, It has to start somewhere, So if you're just doing the status quo, especially with the advent of AI, we're going to be left behind, isn't it? We need to really push the boundaries, see how we can do advanced practice, look at imaging and all that. And I think one of the things I really hate is that sort of box feeling where saying, oh, you're an NHS APP physio, you have to do this, you can only do scan, private physios can't scan, they can't inject. And that model is very narrow-minded, It's like, it's what you want, what you're capable of, and what you work for. So it's open for everyone, We should stop labeling this sort of, you can't be a great rehab physio, plus you can't do ultrasound scan. That's not true. it's you. If you think that's good, I'm like I've been doing it for 15 years. So I have a full, proper private patient list, just like a, physio. But that advanced practice helps me a lot because I can bring the ultrasound here. But I'm sitting in an advanced practice clinic. My rehab knowledge makes a big difference. I can tell them, if you're under, many times I get in advanced practice clinic and they're sending for a surgeon. I ask them about the cadence, overstride, and they're surprised. Are you running physio? I didn't expect you to be here, So that rehab skills will help you there. So it's not like separate labels really, I think that's slowly breaking. Even a lot of clinics in London are trying to get that combined model here, isn't it? What do you think of that, Charlie?
I think almost what you're saying is that a side hustle is good. Having a bit of a side hustle is helpful, and most people do like to learn about different things. They have more than just one thing they want to learn about.
Yeah.
And you took that in your domains, and my version of that is clinical physio as well as sports physio.
Yeah.
And I'm the same. I'm able to bring those skills into both domains with ease because I've spent so much time in both.
Yeah, definitely. And the other thing is, like, one of my colleagues, she does veterinary physio. She treats humans 3 days and, dogs and, horses 1 day there and 1 day. Even for me, my mix here is, you reach a point where you don't want to be clinical 5 days a week. So I work as head of MSK education for Ven Healthcare, which is a Shockwave company. So I love that designing programs, education program, because I can bring that expertise. So sometimes it could be something non-physio as well. It doesn't have to be physio. It can't be patient. But I think the skill mix, I find, will enrich your career, So having the variety, don't put yourself in boxes and say, I'm a MSK physio, I'm a women's, you're beyond that, You can do much more than that.
And you broadened your horizons many years ago and started to teach. And you're now an international teacher, and you're on podcasts, you're doing courses here, there, and everywhere. How did that journey start? Because I know there's a lot of people, especially in this day and age, almost the social media age, people are seeing that as a more of a possibility, more of a career of putting themselves out in the public eye. So how did that start for you?
So again, the same sort of, everything is like accident. And by, again, if you told me that I would be teaching and doing all the courses, like, I would say there's no way it's going to happen. So what I found was, when I was asked to present in services, like in internal departments, the feedback was, people said like I had a good, easy style of teaching, and people found that was useful. And I thought, and I also enjoyed it as well. That's the thing. It was quite nerve-wracking, obviously, when you prepare everything, but the experience was so I felt, and this has been like happening for 4 or 5 years, even with the respiratory, I was quite good teaching. And I thought like I enjoy it. And I thought like, why don't I do this something externally? And somebody's, my feeling, I had zero thoughts that I was good enough to teach with physios. For something in my brain said, I don't have a master's, I don't have a PhD, I'm not so I had all this, I didn't even think about it. So it was not even in my brain that I was good enough to teach courses for physios. I thought like, maybe the people who connected at the time was personal trainers. So I had quite a few physio referrals I made with personal trainers. So a couple of physio personal trainers said, you're good at teaching, why don't you do an evening lecture for us to sort of tell us about common injuries, like knee injuries, hip injuries, shoulder injuries, and what to prevent that. So I did a few workshops there. So, and the feedback was good. So it was like a tenner. So it's quite on that. But for me, the money was not interested in that because I enjoyed that. So hired a small place, gym, end of, 90-minute session, a group of 4 people, So I did around 6 or 8 of those. And one member was also training to be physio, who attended my course. And she said, this is good. Why don't you teach physios? And I can link you up with somebody I know who was, at the time, it was Chris Murphy, who was the head of Physio UK. And he said, he can help you out. And I said, okay, I gave him a CV. And he said, okay, and he said, why don't you do a 1-day course? And I said, oh, you think I'm ready to do a 1-day course? So at the time I was like with another colleague, we did it together. So again, looking back, I didn't feel like I was ready or was worthy to do the course, but I always wanted to do something, So I think looking back is, I was so glad I did that, because if I did straight to a full day course, the pressure would have been too much, because I'd done something which is low level, build up my experience, I've done a lot of in-services. So I've done a lot of unpaid, there's no pressure when there's no pay there. Mm-hmm. And the proof is in the pudding. When the feedback comes in, people want more, it's like when when I go, when people say, "Can you do it again?" It means it's good. Isn't it? People won't call you back if it's not good on that. So again, I didn't plan to be a tutor, but you get better. You have to start small. You need to enjoy it, and you need to have a clear audience there. But I think looking back, one of the reasons I still do a lot of teaching now is it massively enhances your own reasoning and thought process. Every time I do a course, I pick up a few things.
Yeah.
So I get more from the teaching. I'm sure with the podcast it's the same, you get more. I get more from the audience as well. So I think it's one of the best ways to enrich that. So it doesn't have to be like a paid course, but if you do have an opportunity to teach, it's one of the most enriching thing you can do to really start. But I think putting the pressure of commercial too early, I would say that could be problematic, So if you start to look commercially straight away, that puts a lot of pressure, because more initially you start like, is that worthwhile? What's the product like? What's the audience saying? Because you really don't know what the audience want. You come with a product, if people love it, give more of that. If not, change it, isn't it?
And you can start as small as you like. There's always in-house things.
Or even online.
Yeah.
You can do an online module also.
In-house. There's so many ways of just getting used to speaking to a group of people. Because I'm like you to begin with. I was terrified. It was really daunting for me to speak in front of a group.
Yeah. And also market research is huge. For example, like before the course I did, 6 months before, I took time. I spent time with 20, 30 physios, just not like a formal. I was asking physio, what did you struggle with hips? What's the problem? So I was asking from them. It's not about me and my knowledge. It's what they want. What do you think is problematic? What do you struggle? What do you want clarity on? So that market research is so invaluable. So to get from the audience, suppose you have an idea on the knee or something, you need to ask the audience what exactly you want to, and then you need to match your skills with what they want, and then it's a perfect fit, isn't it? Because you might think this is a great idea, but the audience says not really. It's all. So I think spending the time on, all companies do that, isn't it? Market research. So definitely spend some time on market research with your colleagues, and that will give you the direction to go with. Because that's what you're always trying to build, what they want. It's not like I'm trying to showcase my knowledge, because that's not really relevant, because the market will tell you this is what we need, and that will be different based on setting. What's good now might not be relevant in 3 years. You have to adapt on that. So that's quite useful in my opinion.
And one of the courses you teach is a Shockwave course.
Yeah. So main big ones I teach, obviously the hip side, which I teach on that. And then the Shockwave, as I said, is I got involved in the company for 7-8 years. So I use a lot of focus Shockwave because I find it quite useful for the type of job I do with the Pudendal Neuralgia, bone stress injuries. I see a lot of proximal hamstring. The problem with the radial is it only goes up to 3 centimeters. So when you want anything more deeper, pretty much 99% of my clinical practice is based on focus on the Shockwave side of things. So I treat that as well. I've been asked to teach a little bit on the ultrasound as well, because I guess once you get the teaching, you can adapt it to any audience as well. So that's sort of the areas where I mainly teach on.
And I use Shockwave in my practice as well. I find it very useful for stubborn tendons. If someone has been struggling with pain for long enough and they're doing all the right things with their rehab and they're still in pain, then I see it as a really useful pain reliever. I'm now seeing some of the research kicking back at it a little bit, and I think it'd be useful for us to just discuss that topic. And the pendulum is swinging at the moment, I sense, and the pendulum is starting to swing away from Shockwave as a modality, and I'm not quite sure I'm ready clinically to set it aside. It still seems to be a valuable tool for my clients. So what's your take on the kickback that's been going on with Shockwave recently?
I think for somebody who is, I like to believe I'm evidence-based, we have to respect the evidence. So for example, if you look at insertional Achilles, which is a lot of papers have come in, the evidence is very clear. For insertional Achilles, radial is no better than placebo. And you'll be surprised, I teach the same on my Shockwave courses there.
And you're specific about radial Shockwave.
Radial Shockwave. Radial Shockwave really is not designed for anything with bone. But in the study, they do focus there. But again, the problem is when you combine both together, it gets really messy on that. So there's 2-3 things. Radial is mainly designed for superficial tendons and muscles. The focus is designed for mainly deeper structure and also bone stress injuries. So the evidence is not so clear for mid portion. So there's one systematic review which has come from, I think, the Dylan Morrissey group, where they said that for a gluteal tendinopathy, there's good evidence for focused shockwave, and there's very good evidence for calcification. So I think when we look at shockwave, rather than just saying, it's like, for example, saying steroid injection is no good for knee OA. It's fantastic for trigger finger. It's fantastic for decurrent synovitis. So we won't say steroid is bad for everything. So I think when we take about shockwave, it should be condition specific.
Yeah.
So we need to say what type of shockwave for what condition. So rather than saying shockwave doesn't work, it has to be based on specific pathology rather than just labeling it doesn't work for everything. Just to give an example, like, I treat a lot of bone stress, like calcaneal bone stress, sesamoiditis, and there's very good data. And just to give you a bit of highlight, the Aspetar, which we believe is to be good standard, they've published protocols on focused shockwave for bone stress. So if you want, it's open access. They follow in their clinic there. And, so a lot of big groups use that. Most I've done teaching in a couple of Premier Leagues and they clubs, and I've taught them on the bone stress protocols as well. So for certain conditions, it works really well. But for certain pathologies, the evidence is not very, compelling as well.
I think if the diagnosis is appropriate, which I sense is the most important part here, if the diagnosis is appropriate, my sense is that it amplifies the effect of rehab, of good quality rehab.
Yeah. And the main thing would be is also, one of the common line I say to my patient is, if somebody comes with shockwave, I say it's 3 plus 12. And people ask me, what is this 3 plus 12? And they say 3 sessions of shockwave plus 12 weeks of rehab. That's the package. It's not 3 sessions of shockwave.
Yeah.
The 12 weeks of rehab is the most important thing. It just helps you to reduce the pain, gives you window, and I need to load you quite heavily, get you back onto that. If you don't do the rehab, no amount of shockwave will get you out of that, So it's a combined modality. And see, if you got a patient, so one of the big areas you might be aware of is with, I treat a lot of running injuries, get a lot of second opinion with tendons. If you have a patient who comes to your clinic and they've done 12 months of rehab for patellar tendinopathy, they've done 12 months of rehab, good quality rehab, and they come to me for second opinion, what options do I have? Do I have to say to them, go have surgery, spend 2,000 pounds on PRP injections, or try something simple, non-invasive shockwave? Let's be practical. The problem is, you and me, we work in private practice. We have to be pragmatic here.
Yeah.
And we see second opinion. I can't drag them for another 12 months of rehab on the patellar tendon. So this is what I'll say to them. Okay, your rehab is good. I'm happy with your program. You had a scan. You got patellar tendinopathy, proximal, bit of calcification. My job as a second opinion, I'll say, these are the options here. You could go, there are very good consultants I know who do PRP. I can refer you for the PRP for the patellar tendon if you want to go that route. If you want to go, there's another procedure called stripping where they put, hydrodissection, that's procedure there. You have option of focused shockwave, which I can do. Or you have some experimental surgery for your options here. So I'm not picking any side. And lo and behold, everybody wants to start with shockwave first. Is it a surprise there?
Yeah, it's a ladder, right? It's like they're trying to escalate sensibly in their mind.
Yeah, so you've done rehab, and nobody is saying we should sticking shockwave on day one, really. You've done good quality rehab, and then what options you have? So I keep it very simple with my patient. I say, good quality rehab is the first line. You have shockwave, you have injections, you have surgery. Simple ladder, isn't it?
Yeah, and whilst you're doing that shockwave, I'm also going to make sure that nothing was missed in your rehab, right? I'm going to be strength testing. I'm going to be making sure you're moving.
Clear targets.
Yeah, it's like you do all of the other standard rehab stuff just to make sure nothing is missed.
Yeah.
Because I'm not going to do it in silos. I'm not going to do my intervention on its own. I'm going to make sure that they're...
Yeah. And when people rush into invasive procedures, and, if you look at the evidence for PRP, it's mixed, isn't it? Some surgeons will say it's the best thing. Some surgeons say it's no better than placebo. So I have this discussion with so many sports doctors, and as therapists, we don't involve in that. But I find sometimes there's no other option there. So when you look at that sort of intervention there, I think it's much safer to try shockwave before. And some people, PRP might be the option there if you've done shockwave. I've seen some tennis elbow do really well, but this is not my area of expertise. But I'm working in the job of helping people, and they're asking me for solutions, and I guide them.
I think that's completely fair enough, and that's my stance on it too. Yeah. I've got a few questions around classic hip questions that I get from my patients, and if someone says to you they've got tight hip flexors, what happened? What do you start to think of there in your mind? Because it's a classic thing, right? People say it all the time.
Yeah, so I think it depends on the setting as well. So if you get if you get a sort of a recreational runner who had a spike in volume. So there are two things I would say. If it's more a running population, my alarm bells are, immediately saying it's a bone stress, So if you got anybody who had a spiked, like training for the first half marathon, usually the story is going for the first half marathon or the marathon. If you got somebody who's more like the gym type, who is really doing a lot of rotational sports and high impact, I'm thinking it's the first sign of your hip saying, I've got synovitis, I have an underlying impingement or early OA or dysplasia. It's a sign. But basically, the key thing is somebody who scans hips will know that on the top of the capsule, the most closest muscle next to the hip is the iliopsoas. Anything wrong with your hip, it's going to irritate the iliopsoas. So the iliopsoas is a symptom. The hip is not happy.
Yeah.
It's just saying me, I'm a bit grumbly here. Because the problem is, let's say you got a knee problem, because I'm sure, like me, you see a lot of knees here. You got something with an ACL. You got a bit of swelling. You can feel it, isn't it? You can see the warmth, see for effusion. But what do you do with the hip? You can't really palpate the hip and look for effusion unless you have an ultrasound. You can't really feel it. So the body is telling you, I got irritation there on that, So it's nearly always an irritable joint as well. So those are the two things. Having said that, there are a few exceptions. The tight hip. I find sometimes people who do, like the dancing population, who spend a lot of that hypermobile population, or the kicking, who doing martial arts, they tend to get true iliopsoas tendinopathy, or do explosive stuff, where they do like high kicks, sprinting, hurdlers. But that's not the normal group. Most of the time, it's either a bone stress or an intra-articular pain. That's usually one of those two.
And then you got someone who says, I'm struggling to engage my glutes. Can't get my glutes firing.
Yeah. So I think that's quite a common thing, and say they can't activate, that sort of thing. So I think one of the things from physio side, which is really improved now, is really using objective testing like handle dynamometer. So I really use it with all my hip patients. I check their abductors, adductors, do them some functional testing. So I don't dismiss them. I do it, systematic testing, and then show the numbers and show them, actually, you're not weak. Your strength is good, Sometimes it's more a motor control. It's more an engagement thing, So, but they've been told by many people that they are not engaging. So sometimes you have to give them data to prove it.
I think with some of them as well, they just can't feel it.
Yeah.
And the feeling is different to the reality of the output. And sometimes it's helping the person learn the feeling.
Yes.
It's like, get your hand on it.
Yeah.
Feel underneath your hand.
Yeah.
You feel that? That's your muscle contracting. Yeah. And I play around with this all the time with people because, as you said earlier, I'm a pragmatic private practice physio that wants to help people.
Yeah.
And if that person's problem is that they can't feel their glutes, it's like, well, let's play around with that. Let's figure it out.
Yeah.
Play around with different exercises.
Different positions of the feet with a bridge,
Exactly. Yeah. Further away, longer, wider.
Put the bands in different locations. Yeah.
I don't care whether the EMG changes with those things. I'm not bothered. I want them to feel it because that's the problem they've come to me with.
Because you must say, in fact, I had a patient today. I gave him exercise and said, I don't feel much at all. And then they don't engage at all, because the feeling seems to be important for them to feel like you're working on that, So you have to make it relevant to them and see whether they feel perceived that engagement, And you're right, otherwise the compliance doesn't work,
Yeah.
On that.
Yeah. And you often get this, the older person as well, who'll come in and say, I can't run anymore. It's not possible for me to run anymore. It's not safe for me to run. How not even necessarily older, actually, maybe even the younger hip that's got OA or they've had hip replacements. How do you feel around that?
Yeah, this is quite a common thing, especially when they've been given a diagnosis of OA, early OA, because I think one of the challenging group I see in hip is that sort of 35 to 55 OA, but not bad enough for a replacement. It's a tricky group because they've got mild OA, symptomatic, but the surgeon said, let's wait, There's 2-3 problems with that. One group, what they do is they shut down everything. They feel they're going to wear it out, They feel like they are not going to do that, and they get deconditioned and they really stop everything. And that's a big problem because we know once you don't exercise, especially in middle age, we get a lot of health issues as well. So first thing I always check is I always ask them the baseline. What did you do before? So somebody who has done a lot of running and a lot of things before, they will usually have stopped totally running. So we know from the evidence that, especially with hip and knee OA, there's no evidence that running will naturally progress that. But I find from my experience, people with symptomatic OA, I find up to 10K seems to be doable. If you ask me to do like a half marathon, 1 marathon day one, I feel that might be unrealistic, So I find even with symptomatic OA, you could really get them back to at least 5 to 10K in the first year and then build it up from there. So I said to them, obviously explain to them that running doesn't cause more damage. It's safe, one of the safe thing to do, but we need to make sure that your joint is ready to take the impact forces, So initially I might give them 6 weeks of a lower limb, a bit more head specific, a lot of cross training, check them, and then see the gait analysis cadence, put them on a boring walk jog program, ease into it. So I think with good preparation, you'll be totally fine. So I think the couple of things is you're not going to cause any damage to the hip. You already have osteoarthritis and it's not going to get worse. Worst scenario, you'll be stronger if you need replacement. So it becomes like a prehab, So a lot of times I've got people like easily to 5 to 10K, but it's a slow process though. It might not happen overnight. But somebody who's not run for 1 year, you can't get them overnight because they've been told on that. So I think that message is slowly changing that even if you have symptomatic OA, you don't need to stop running. But the distance will vary. For some people, a bit of park run is all they need. For some people, it could be 10K. Sometimes you might have to push on to that. And even another big one, which is, I was talking even before we started, is I'm seeing a couple of hip resurfacing patients now. And there's a lot of centers in London who are doing resurfacing and even like anterior. Many of patients, even after replacement, we get them back running. I only work with consultants in the hip world who all encourage running even after hip replacement. So sometimes it's working with that consultant who shares the same philosophy. So luckily I'm in a position where pretty much all the consultants I work with have zero problem with them. But they'll tell me, don't rush, wait for 6 months. So if you had a resurfacing, we don't rush them. So wait for 6 months and get them back running,
I think that's a really powerful message that was hidden in there, is that we could be selective about the consultants that we work with too. It's not just about having to just do whatever the consultant says. And I think there's just, we're the experts in our side of things, physio rehab, and they're the experts in their side of things. And we work together to get the best outcomes. So I've worked really hard in my career to have a network of trusted doctors, consultants, physios that share my values and do things in a way that's in line with me, with my style.
Yeah.
Because I would be mortified if my patient came back and said, God, I can't believe the way they spoke to me, or can you believe that they're saying that you shouldn't run after all? And I'd be like, oh God, banging your head against the brick wall. It's really important that I've developed this relationship with that consultant over time.
But otherwise it's conflict. If you've got a surgeon say you can't run, it's not going to go anywhere.
You're not going to change their mind.
You don't want to change the mind, So I think, luckily the consultants I work with share the same sort of forward outlook, and they say, that's Benoy's territory. You discuss with him, he'll tell you when you're ready to run. So they give me full, that clearance there. But I'll ask them, what's the minimum timelines, For example, they'll say 6 months. I'll respect that. But then whether they run in 6 or 8 months, that's up to me, So they have to hit my guidelines. They have hit that. And fortunately, most of the people I work with will send me those patients as prehab. That makes a big difference, in my opinion. If you see those patients before the surgery, especially if you're going for a hip resurfacing or a replacement, I get them in, go through all the key exercises, give them the carrot and say, I'll get you back there, So they're motivated there. So getting that sort of initial compliance and that connection before the surgery makes, even if it's 2 sessions, do that. Do you do that with your post-op, anyone going for major surgery?
Yeah, if I get the opportunity. Prehab is an absolute standard now, and it's I always just say to them, you're just investing in the future. Is the better you are going in, the better you are coming out.
The more stronger you are. Yeah. I took this line from one of the knee surgeons. He was saying like having a knee replacement is like being hit by a car or something. If you're here, you drop down only here. If you're here, it's so hard to come up, Yeah. So get your baseline at a good level. Then the drop is not too bad. Then you can really go up on that, So I think the prehab really help. It might not, again, it's one of the areas very hard to prove by research.
Yeah.
So if you look at the research, there's not much evidence for prehab in most of the things. But I think the compliance and the motivation is invaluable.
The psychology of it, I think, is super powerful. It's just having someone already understanding, firstly, my methods and my style, but also helping them with the expectations of what's going to come on the other side of it. And I get really good feedback regarding people that have come out of surgery and they're like, God, I'm so glad I did all this stuff beforehand. I do feel like without having done that, I'd have really struggled at this stage. So yeah, anecdotally, I find it, people really like it. Really happy.
And also it sets the scene and they know clearly what to expect and we can go through that. So I think that's why spending time with the consultants, we have a common pathway. because obviously important decisions like when can I drive, all those things, I still, it's very important the surgeons give clearance there. For me, it's the rehab side, I stick to my strength, which is like getting them back to the gym, getting them back to the sports, that's once I'm happy, the surgeon's happy with the surgical clearance, which usually are around 6 weeks. Then they'll say, just follow what the rehab says. But following certain big surgeries like implants, you have to, especially if you're doing uncemented, you have to give it time for the bone to grow into that region. And that sometimes takes 6 months. There's nothing wrong with the implant. It has to get firm, So we need to respect biological healing. Yeah. People will say, can I run in 3 months? You could. Not a clever idea, So wait for that 6 months, especially when you're doing like a big, and I say to them, you can do in 6 months if you hit some markers. Yeah. So I give them clear markers, gym markers, body weight markers, handle dynamometer markers, and then at least 2 weeks of plyometrics, get them back like a graded return, It's more like progression based on criteria rather than in 6 months you're ready. It doesn't happen like that. Same with any surgery, isn't it? Yeah. You build it up gradually on that. So that makes sense.
10 to 15 years ago, when I was just getting myself started as a physio, a young whippersnapper, there was this shift away from what FAI surgery was still massive. Everyone was getting FAI surgery. And then there started to be this wave of studies coming out that actually physios have got a role to play here. And then it was like, physios can fix all of these FAIs. And now, as with anything, it seems this pendulum has landed somewhere in the middle and it's kind of done on a case-by-case basis. What do you think the future holds for hips and physios? Is there going to be a wave of stuff that you can already sense coming? You're at the forefront of this. You see the things that are done regularly, and you must have some thoughts around things that are maybe done too much or stuff that's done too little. What do you think the future holds for the world of hips and orthopedics and rehab?
Yeah, I think it's quite an exciting area. I would say whenever I teach courses, I say the hip is at least 20 to 25 years behind ACL. So when you look at the established areas like ACL, it's well set. With the hip, for example, if you asked me 3-4 years ago how to manage proximal ITB, I had no clue. I didn't have that. I can tell you now, I didn't know what to treat it. So there's more to be explored. There's more to be found in that. So one thing what we'll get better is identification on the subgroup. For example, we're still not knowing which is the best group for hip arthroscopy, who's best. So that data is still coming. We know that below 40 is good, without OA is good. So I think we'll get more precise in patient selection for that. So I think that will help massively. Right now, before when it came, it was for everybody. Now we know it's not so great for everyone. It's a small group who benefit from that. And the second one, I think, is really big advances in the replacement, where we'll be pushing our patient much more than what we did before. So I'm really excited with the hip resurfacing studies. I've seen a couple of patients, they've gone back to full sports. So it'll be a less invasive, more keyhole based, things like that. And I think also a big one will be technology. There's no doubt around it. So I use pretty much all the gizmos you guys have, BFR, muscle stem, things like that. And more and more physios are involved into diagnostic ultrasound. So one of the things I do quite a bit, which is quite, I would say very few people do that, is I can check hip instability with an ultrasound. So I put them on the couch, put the ultrasound, look at the capsule, stretch it out. If it goes more than 2 millimeters, then I know they got hip micro instability. I can see dynamically. So I think more and more people will start using dynamic testing, in place there. So it's more objective. I think it has to be more objective in how we do that. And that's great for the patient. And the final point would be is definitely more holistic, where we'll be looking into bringing in nutrition. So one of the things, a big change for me with runners has been is, I can't believe I didn't do this, is every patient I go detail on their food diary. I didn't do that before. I thought I was a physio. What the hell am I need to know about the calories, But now that's the first thing I ask, isn't it? How much are you, especially with bone stress, So really go on that. I didn't really do much on the nutrition side of things. So I think the nutrition, and I'm learning more on peptides. I'm not saying this is not a forum to encourage, but I know many of my patients are taking it. I need to know what they're doing. So I need to know the biohacking side, So physios will become more like coaches, like health coaches there. I see myself more like a health coach now, because most of the time it's guiding them onto that. This is the person. So I work closely with 2-3 online nutritional consultants, because a lot of my bone stress, they need that help. I screen them, but I don't have the skill set. That's not my area of expertise. I arrange them online where they can arrange nutrition side. So I think the more we integrate with those sort of MDT, it'll be more like getting that health coaching. So physios will become more like health promotion coaches,
Well, you're on the right podcast. The Physio Coach Podcast is all about this stuff. So thanks for kind of supporting our mission, because that's really what I've sensed, that my complex case success has come from having a broad ability and knowledge across those different pillars of health. So I fully agree with that.
Can I pick one before I forget? Is people ask me what has changed with me in the hip side of things. Clinically, I don't think I've come with any brand new exercise or anything in the last 4 weeks. What has massively changed is I have such a good network of, a must in hip is women's health, pelvic health. I would say 90 to 95% of my chronic female patients, that's a good point. Every female patient who comes with chronic hip and groin pain, whether it's an impingement or dysplasia, I'll always screen for, I'm not going to do any examination here. That's not my area. Simple question. Do you get pain during sex? Does your pain increase during periods? Do you have bladder issues with urination? Do they have a difficult pregnancy? Do you have a history of prolapse? Simple 4-5 questions, which I think we should routinely ask any female who comes with hip and groin pain. And then if the question is positive, I'm going to say, I think you need a pelvic floor input here. Because that will make a big difference in my outcome. I'm a bit selfish here, because if the pelvic floor is not addressed, no amount of hip rehab will work. That has to be addressed. So working very closely with pelvic health, especially with female, with the stuff there. Big on nutrition, especially with the bone stress side of things. Very, good consultants who can do the diagnostic. One big area, which is injection is really useful, is diagnostic. So you got like a bit of mixed picture. So I trust a few consultants who will do like a diagnostic block. So I had this patient, basically, she came, in fact, she flew all the way from Germany, which I was a bit surprised. She came in the morning, she's a student, and she found me because I did somewhere on Pudendal Neuralgia, and she came to me. I thought she had Pudendal Neuralgia, but her pain was on the obturator nerve. It's pretty much more on the adductor region. She had a bit of strain during an accident, burning pain in the inner thigh, adductor origin. I thought it's obturator nerve, but I can't confirm that. So I booked with a sports consultant for an obturator nerve block to do a diagnostic. That will confirm that. Then I can do the rehab, So you must have access to those specific sport consultant there. And of course, the surgeons. So I think the confidence I get is not because of me, it's the team, I know I've got people who are covering my bases there. Although I'm not working with them in the same place, they're all in London, So I'm sure you do the same, isn't it? So you can't be a good hip physio or a shoulder physio, knee physio on your own, in my opinion. You need the people to support you.
You can't be a good physio on your own. I think that's the key here.
Not any, because you can't do it on that. And the more I've worked with people, it's made a massive difference in my outcomes, that pelvic floor input, that nutritional input there, some personal training. I'm a big fan of Pilates as well in the early stage. So I work with a couple of Pilates people. So I'm looking, it's not like this patient, what's the best, when I used to think early stage of my career was, what's the best physio? Now I don't ask that anymore. What's the best for the patient here? What's the best package for the patient?
So I used to think, what do I need to do in order to help this person? Now I think, who does this person need in order to get better?
And what's the team the patient needs?
Yeah, that's it. Team, it's like, what's the team that needs to be wrapped around this person in order to get better? And there's a good chance part of that's because both of us see more complex cases as we've gone through our careers.
Not everybody needs everything.
No. Yeah. But when you're seeing someone who's had pain for many months, often many years, then there's a good chance that they're going to need the MDT.
And another big one I left out is the pain clinics, pain consultant, where sometimes you need some complex drug intervention where I'm sure when you work with chronic pain, you work with some pain consultants there. So where it's more, just give an example, like I had a patient who had, about 5-6, elderly patient in her 70s, chronic knee pain, can't have surgery because of cardiac issue. Had tried everything. Have tried, steroid, PRP, few drugs and everything. Not much change. And then there's not much physio I can do. So I said to him, he came to me for an opinion and said, I know you can't do anything. I've tried everything. Is there anything I'm missing here? I said, yes, actually, there's one thing. There's something called a genicular nerve block. So basically, it's done in pain. A few consultants do it privately. So the nerve supplies the knee is called a genicular nerve. So what they do is they go by radio ablation, basically burn that nerve. It'll give you about 6 to 9 months, give a year. And that was game changing for them. It gave like a year of pain relief. So again, it's a specialist knowledge there, So I'm not saying like, I can guide them there and say, I said, that's the consultant who does that. Please go ahead. That's the only reason he came to me, is to find, is there something else I'm missing here,
We started off the episode saying the eyes can only know what they know.
Yeah.
And what we're realizing here is that the eyes can only know what they know, but other people's eyes know what they know, and other people's eyes know what they know. So it's about knowing whose eyes are needed in the situation.
Yeah.
And we're here inviting you to be the expert, and you're quite humbly saying that you are only just one piece of that ecosystem of experts out there that help these complex cases, which that's important, because when you're young in your career, you do get this sense sometimes that you need to learn everything in order to be a good physio.
So your one thing, like making a referral to others is like a failure thing. It's not at all,
Exactly.
Most of my patients are managed by 3 people simultaneously.
Yeah.
So, and I think, and also it prevents me from burnout because I'm not entirely, because many of my patients, they try to dump their entire recovery on me. I say, no. This needs an MDT, I'm not, I don't have the skill set to manage on their own. Obviously, if you've got like a simple patellar tendon or something like an Achilles tendon, you don't need a massive MDT for that. But if you got somebody who has failed back surgery, failed knee surgery, complex hips there, I say to them this needs a whole outlook here. And I think people love that, because people know that you're not trying to reassure them you can eat all on your own, because no human, I don't think you can do that, isn't it? So the pressure is, I think that reminded me, it was when I first started at hips, maybe after 3-4 years, I was so close to a little bit of burnout there, because a lot of my chronic hip patients were expecting me to fix them, and I couldn't, because I don't have the skill set. Now I say to them, it'll be managed by a team, but I'm the conductor. Yeah. I'm like the coach here. I'll guide you, this pelvic floor pain clinic, the drug, I sort of guide them on that. And that, I think that's a valuable role, in my opinion, because we can all be in these little boxes there, and you can say, that's not my problem, I'm a physio, why should I know that? I would disagree with that. For me, it's not good practice for the patient, because the patient needs to be exposed to all possible avenues, isn't it? Rather than me, because sometimes we can just stay and I say, this is not my remit, but I'm just guiding them, because, suffering, I don't want that, because there's one line I'm sure you heard is, pain is inevitable, but, suffering, is not, suffering is something we can help. When I see somebody distressed, especially that brings back my memories of my knees, going through that. I think unexplained pain can be distressing. Yeah. So that can really put them off. It's knowing what's wrong and why I'm suffering, because it doesn't have a meaning. It doesn't have any relevance. You're having this pain and you don't have any sense of meaning. And that can be quite debilitating. So at least we can give them a meaning and a plan. Sometimes that's all we can do. We can't fix them, but at least it's more like mentally reconstruct, changing the narrative, isn't it? Sort of thing. I'm sure you must do with that sort of chronic pain cases, isn't it? There's nothing more you can do.
And in the end, it comes down to being expert communicators. You've got to be able to communicate with these patients about difficult, sometimes unknowns, being able to be, I call it sitting on the fence with confidence, It's like you sometimes need to say, I don't fully know at this stage, but this is how we're going to find out, you as the conductor, guiding them through the journey.
Yeah, and the problem with, one of the issues with modern medicine is we have got so specialized, like endocrinology, we don't communicate enough, You're so good at one thing, and rheumatologist, all that is great, but sometimes as a physio, I still like to see as a generalist, I look back and say, what's glaringly missing here, And that's the problem with super specialty, isn't it? That's one of the main reason I don't only say hips. I still say a generalist, because the danger is if I see hips all day, every day, 5 days, I'll just get so dumb with that, because I'm missing out the spine. I'm missing out on the knees, the kinetic chain, all that, because the danger of just super specialization. Would you agree with that?
Well, I read a wonderful book called Range, and it talks all about that exact dichotomy of the super specialist versus the expert generalist. And I very much sit on the expert generalist side,
expert generalist,
which is fascinating, because I'd have put you down as a hip super specialist, but you're quite rightly saying that there's a lot to learn by making sure that you stay open-minded with other physio practices and other health-related.
And occasionally I like to see the shoulder as well, just to see, because I like the scanning of the shoulder as well, because it gives you a different perspective, isn't it? And we don't want to put like in a small hole, like your brain can only be good at one thing, That's more, it's like, you ask, it's like how many languages can, you learn? Like a baby, it's like, if you, like where I come from, Southern India, most people within the community, they speak 6 languages, 5-6 languages, but we never thought it was difficult. It's what we do there, So sometimes we put all this sort of different difficulty there and say it's so difficult to learn multiple languages. It's not. If you grow in a society where everybody speaks 4 to 5 languages, You have to do it, So I never found that was a problem, because I grew up in that environment where you have to learn. I had to speak one language at home, one at school, one with my grandpa was different language. So that was normal. But now people say, oh, you must be clever. It's not really. It's more your belief, I think, It's more like you think it's a bit difficult on that. So again, trying to put yourself in one role, I think you're just limiting massively. And especially all of us, we're going to have a long career. Unfortunately, we can't retire very early, isn't it? It's getting pushed for. So do you want to have more variety and fun than just one little, area there?
And I guess it's important for you to have a think about this final question for us, which is the same question for every guest, which is, what does better never ends mean to you? It's the tagline for my life. So I live my life by that mantra. And what does that mean to you in your life? Better never ends.
Yeah, I think for me, it's better never ends. For me, it's more like the curiosity, So it's more like being curious of how to be better. For me, it's like the appreciation of what I can really bring more to the person, to myself, rather than putting more pressure on me. So for me, what's driven me all along has been curiosity. What's the problem? How can I help? How can I sort of expand into that rather than, I'm passionate about it, all that stuff. Because initially, you really don't know what's going to work. That's the reality, You have no idea whether it's going to work on that. So having that unbiased opinion of curiosity and to really push your boundaries there, I'm a learning, I'm a growing. That's pretty much what's driving me now, because I really, don't know where I'll expand more in the next 5-10 years. But that's the exciting bit, isn't it?
Yeah.
So on that. So if something new comes up, I'll say, okay, I'll try that, because the danger is not to label yourself, oh, I'm a hip specialist or I'm a running specialist. I want to do, I want, So it's having the curiosity and the flexibility. Then I think the better will never end, because you will merge into the next, which is never changing is change, isn't it? Like, so that the curiosity is, I think it's a more healthy mindset rather than the pressure of you have to love it, you have to have passion, all that. Because I think that line is overused, that sort of driving. You need to feel a spark on that. I never felt a spark with anything initially, but I started liking once I enjoyed the process there, isn't it?
And Benoy, there'll be plenty of people now that will be keen to come on your courses and find out a bit more about you. How does someone get in touch?
Yeah. So I'm all pretty much on all the, social. So one thing I forgot is my podcast, So I've got a podcast called the Straight from the Hip, where I discuss with my good friend Callum. So we have a bit of a banter on, I think there are a few things which can't be covered on courses, bits and pieces where I felt there was no dedicated on that. Obviously on all the socials like Insta, and it was where I, share all the course details, but definitely feel happy to DM me, if you got anything on the query or of that. Again, if it sort of opens up on the differential diagnosis, helps to pick up these cases early, and we can help these patients, then I think that's done the job. And so glad that, I have the forum here to raise awareness of these pathologies, which are quite missed, They don't fit in boxes, So these are sort of the weird cases, but for some people, it can be extremely debilitating. So if we can help them find the right professional, I think possibly, the job of the podcast is done, isn't it? We can help more people. That's what you become a physio for, that is to get people better, and also relieve their distress and the suffering. That's what drives me every day.
My eyes now know more, so I feel confident moving into my next hip patient. So thanks very much today, Benoy.
Yeah, thanks, Charlie.
Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with JNAT to see it for yourself. Use code Physio Coach 2MO to get 2 months free. To stay up to date, follow us on Instagram at Better Never Ends, or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's better physio.